We are going to now have another panel session, and we're going to be talking about healthcare. We're going to talk about the opportunities to utilize AI for real impact as well. I'd like to welcome to the stage Professor Martin Curley, Professor of Innovation, Maynooth University and Digital Health Leader, Dr. Simon Wallace, Chief Clinical Information Officer at Microsoft, Medical Doctor, Digital Healthcare Advocate, Anna Chevillier, a young AI role model of the year 2024 at the AI Awards and former AIPREMie, and Filippo Sassi, head of AI labs at version 1. So healthcare is at an inflection point, and AI promises to solve burnout, improve patient outcomes, reduce administrative burden. But how do we move from promise to practice? And we really want to explore some real implementations, ethical considerations, and what actually Ireland's healthcare system needs to embrace AI responsibly. I put up a post on LinkedIn about what questions I should ask at this, and I got a few comments on the post, but I got so many comments, actually direct messages. So this is something that everyone's got skin in the game on as well. Simon, if I can start with yourself, we start with the patient in the room. What's the best practice for a clinician to introduce like an AI listener to a patient, or how do we look to do this while also maintaining trust? Because trust is obviously fundamentally important, but I think we all agree something has to change in healthcare.
I couldn't agree more. I think one of the most important things is to involve the patient from the get-go. Dragon Copilot is a tool that allows a clinician and a patient to have a conversation. That recording then to provide a note or a letter for the clinician to save him or her having to type it. So the key to it is asking the patient or that I'm going to be using this tool to help me with my note taking. Are you okay with that? We've found from the work that we've done, all patients say, yes, thank you very much. And what they get out of it is a much better engagement with their clinician, the eye-to-eye contact, that sensation that, goodness me, there's a real listening going on. And you can ask permission, but you can also, for example, have information leaflets in the waiting room of the outpatient clinic. That there are lots of ways to do it. And the outcome of that sort of engagement is that from a survey we did, 93% of patients really felt that having this tool led to a better consultation.
One of the things that blew my mind, and if you haven't seen the podcast episode we did with Simon a few weeks ago, is how much time is spent with administrative duties. It's just absolutely incredible. If I can bring Martin into the conversation, what are you seeing kind of for people who are under so much pressure from a practical side to help them kind of, reclaim their time, help them? What are you seeing on the ground?
Great, and congratulations, Mark. It's a fantastic event, and it's brilliant that you're doing it. Healthcare is a really task-saturated environment, and from an innovation perspective, the absorptive capacity of any system when it's so it's very low. So one of the key things we need to do is design for adoption, and we talk about that in Open Innovation 2.0, making things so easy, so much better that it's just a no-brainer to adopt. And I think tools like the Dragon, the Nuance tool is a brilliant example of that. It just makes it so easy for a clinician to adopt it. You just speak to the EHR, you can be focused on the patient. But just one real example, actually right behind us is Hanover Clinic. Dr. Frank Kenny is the GP there and is the CEO, and he's been adopting a similar tool to the Dragon tool for his practice. And initially he was really skeptical, so it's not going to be able to capture the data reliably. And what he says now, actually, previously, when he was writing the patient notes, he actually missed about 40% of the content. And what Frank has done is integrated that into his clinical workflow, and the engagement is fully annotated. And by the end of the appointment, myself as a patient, I actually have the full transcript and the medical notes on my phone. And just to give you an example, I had the privilege of doing a speaking tour in Australia and Indonesia a few months ago. I actually got Bali belly. I was quite sick. It was the same thing that Hugo Keenan got, lost about 6 kilos. I actually had a remote call with Frank. It was fully AI annotated. And at the end of the call, actually had all the details on my phone. And it's eliminating all of the administrative work. Another guy, Ray O'Sullivan, he runs First IVF in Clane. He's a gynecologist. And he's completely eliminated his admin work, and it's producing better quality responses. So it actually is the killer app for clinicians. We've been waiting for a long time, but it's here now.
Because when I go to a doctor's appointment, I'm always thinking about me, and I'm not thinking about the GP. But a lot of the time, the GPs are more stressed out and sick than I am. In some cases, you can see they're flustered, they're doing so much, and if they're practicing but actually spending so much time on the administrative task, it's going to take away from their kind of experience of actually doing what they love.
And we talk about the quintuple aim, like when you deploy technology, you're looking for 5 benefits, better care, lower cost, higher value, better patients, better clinician experience, and sustainability. I was speaking at an event last week in London. I don't know if you know Adam Kay. He's a comedian, but he wrote the book, This Is Gonna Hurt. But he was talking about, the average midwife in the UK, they have 3 weeks of sick leave a year, and that's a huge amount of time. But he quoted there's 70 doctors leaving the NHS every day because of fatigue and low morale. So these tools, I think, this is the killer app, and it's going to transform not just the patient experience, but it's going to allow doctors actually and nurses have a much more sustainable lifestyle and get rid of the admin burden, because doctors want a doctor. They don't want to be documenting notes. And so I think this is a real breakthrough.
I could bring Anna into the conversation. Some in this audience will know about AIPREMie and some of the work that's happening there, phenomenal work. Would you mind telling us what it's been like in your role there in the past of actually going on the journey of getting the data, the amount of different types of stakeholders to bring them all together, and some of the outcomes that actually can come together with such diversity of stakeholders?
Yeah, it's not easy. So it's been touched upon in some of the videos already, but the hospital systems in Ireland are truly legacy systems. The data is fragmented, and you want to be creating something that's interoperable. And I think, Martin, you already touched on it there, that kind of time-saving element. If this was a research project, we weren't trying to sell it to the hospitals. Just for context, AIPREMie is a clinical decision support tool for helping diagnose and risk stratify preeclampsia, which is a pregnancy disorder. So when we were going into the hospitals and trying to, speak with stakeholders, which were the obstetricians in the 3 big Dublin maternity hospitals, the conversations we were having, they all saw the benefit of having something like this to help risk stratify, because it's such a difficult disease to pinpoint early in pregnancy. So they all saw the benefit. You don't have to sell the benefit. You have to mitigate the risk, really. So you have to have these conversations about patient safety. And that was one of the comments I saw on the LinkedIn post is, we talk a lot about this risk, but when does patient safety come before risk? And how can we use AI to mitigate that patient, or to help patient safety? We're working with AIPREMie. One of our kind of goals was to see if we could help identify whether we'd be able to diagnose people of colour a lot better than clinicians might be able to do, because people of colour are very much underdiagnosed with preeclampsia because they have a tendency towards hypertension. So if you have a tendency towards hypertension, you're already coming in with high blood pressure, and it's just being missed that these women are actually preeclamptic from baseline. Another thing there is, the ethics. If you're introducing any kind of proof of concept into the hospital, have an open conversation about the ethics. How are you going to get informed consent for all of this data? What's going to happen with the data? Where is it going? How is it going to be anonymized? Because once it's in an AI system, it can't be taken out. And I don't know if you've ever looked at the ethics forms in hospitals, obviously you have, but you have to give them the patients the opportunity to take their data back. But if it's already in an algorithm, how do they take that back? You know, there's a lot of nuances there with ethics and data. Yeah, and there's that kind of time saving element as well. So if you want to bring a POC in, how you don't want to add more to that admin that they already are spending 90% of their time doing. So how do you make it easier for them? There's that linked in with interoperability, but their systems in the hospitals aren't built for interoperability. So how do you make it easier for them? So those are the conversations.
If we could just pass that to Filippo, because that kind of leads in nice to the question I have, because you're building AI solutions at version 1 globally. What are some of the unique challenges of actually developing AI for healthcare versus other industries, and what's the big difference about it?
Yeah, well, regulation applies to all the domains nowadays, and the previous panel, someone was touching upon the challenges of a few regulations like the EU Act. Healthcare is obviously a very sensitive field because of the sensitivity of their data. So what we're trying to do is obviously to anonymize the data wherever we can, is to employ...
Filippo, I might need you to just move the mic a little bit.
Oh, sorry. Can you hear me better now?
Yeah.
Is to anonymize the data whenever we can, is to use guardrails to be sure that the data is processed in the right way, and optimizing the prompt, optimizing the parameters. So these are a few of the measures that we're taking care when we're operating in the healthcare industry.
So having the guardrails, being cognizant of doing it, and kind of similar to Simon telling about Dragon Copilot, you've also got your own research, and it was quite interesting what you found from some of the products that you had.
We did indeed. So this is a solution that we have been exploring for our customers in the States. They have practices all over the countries. And each of the practitioner they're supposed to talk with patient for 45 minutes, and then they have 15 minutes to do the admin work. But patients are often late, sometimes appointment overlaps, so they never have the time to do it in these 15 minutes, and they have to do it at nights. This is not good for many reasons. First of all, it's stressful for them. They're not paid for this work, so high turnover. But it's not good for patient either, because they are recording information that have been taken during the day at night. So sometimes they confound the information from different patients, etc., etc. So third-party tools weren't an option there, like Dragon, because they were worried about two things. One is cost. They have a lot of, about 1,000 of practitioners, so the scale of voice-to-text the cost would have been very, very high. And the other was customization. So they wanted a bespoke solutions because they have evolving needs, evolving changes, and they wanted the application to be tailored for them. So what we did was first to analyze many voice-to-text models, and we were able to identify one for a small partner, but very accurate as the others, but for a fraction of the cost. And then we use the informations we are extracting for running a number of ML, NLP, and generative AI to extract the information and fill in all the details into a form. They just need to edit if they need and push the button. So instead of 50 minutes, now it takes less than a couple of minutes. This is beneficial for them because obviously it reduces the admin burden, but it's good for patients as well because the information is in real time, so it's much accurate.
Yeah, because even because you're talking about 15 minutes or so, I remember even when Simon was saying you could say between 5 to 6 minutes on every GP appointment. And that doesn't necessarily sound a lot, but when you scale that across the country or across the world, suddenly that actually starts to add up. Simon, if you look at beyond dictation and kind of ambient listening is the first step, what's the next logical step? Where does it go? Where do you think the next step is going?
Yeah, so if we just take an outpatient consultation, the admin burden in that, 50% of that is actually creating the notes, the letters, the referrals, whatever. The other 50% is sort of actions, ordering the medicines, requesting some tests, and other things. So once you've got a good quality note, and the healthcare professional, whoever that might be, this is not just for doctors, it's also for nurses, allied health professionals. But once they are realizing the benefits of saving time, by their notes being created. Then the next bit is to take some of the other clicks out of the day-to-day workflow they do. And that is involving the electronic patient record. You'll see clinicians, if you've been to your GP or hospital appointment, hunched over their keyboards, busily trying to get everything in. The key next step to your question is our voice being able to take those clicks away so that embedded and integrated into the electronic patient record, I can prescribe my medicines using my voice. I can order my CT scan using my voice. So I think that is the sort of the next big step. And we've seen lots of other examples of well from the finalists here today. Two non-admin applications of voice. For example, the conversation that the two of us are having, there's now the ability for algorithms to detect, is there any hint of stress, anxiety, depression in that patient's voice? What about heart failure? Heart failure essentially is the retention of fluid. My vocal cords, if I've got a little bit of heart failure, there'll be a change in the way the voice sounds. And that's very subtle, but the trick about heart failure is picking it up before some acute episode happens. So just a couple of examples of how a technology with our voice is going to transform things going forward.
And actually building on that, Martin, if you could give us a bit of an overview about some of the promising AI that can actually be a point of care devices that we can start to see the value from.
Yeah, there's some really exciting developments in building on what Simon said. Just first sort of point of care ultrasound in Ireland, cardiovascular, actually it's the number 2 cause of death. But we have in some parts of the country an 18-month waiting list for an echo test. And statistically, about 20% of the patients will die on that waiting list before they get seen to. Now, an untrained person using, say, a GEV scanner or Butterfly using Caption AI can actually do that in 3 or 4 minutes. So something that used to take 18 months and, it's a 10-minute procedure can now be done in the GP's surgery. I recently had it done on me in NHS Winslow. And when I was in the HSC, we had the director of oncology in Beacon Hospital do it live without a safety net on Dave Burke, the cardiologist, and it worked really well. Another simple device, I don't know if people know the AliveCore Cardia. It's a small device, does an ECG in 30 seconds. It's 10 times cheaper, it's 10 times faster, 10 times more convenient. But 2 examples of how that is actually really adding value. When I teach, I have a beautiful video of a 78-year-old woman that used the AliveCore Cardia and her Fitbit with her GP to diagnose her condition of supraventricular tachycardia. And she'd been to see 3 cardiologists and they hadn't been able to detect this disease because it wasn't happening when they were in the hospital. But it literally transformed her life. She had an ablation and it was a life-saving condition. But I was recently in the back garden of a top Irish clinician. He runs a rehab business. He was a top sportsman. I was trying to convince him to use the AliveCore Cardia as part of a rehab program. And I said, let's call him Colin. Here, Colin, let's take your ECG. And in 30 seconds, I was able to say to him, actually, you're in AFib now. He was completely shocked. And in the past, that might have been something that would have been discovered too late. 50% of strokes are preceded by AFib. So that's an example. Another beautiful device coming out of Copenhagen. It's called a SeismoFit. VO2 max is the single best predictor of longevity and healthy. It's about the amount of oxygen that your blood can absorb in exertion. And previously, to do that, you had to get on a treadmill or on an exercise bike. And we've been trying to we have a beautiful project with Sean Gain in the Mater Hospital with patients with pulmonary arterial hypertension. And now in 40 seconds, using an AI tool, a person lying flat, we can actually measure their VO2 max. So we had a workshop in Maynooth. I had a lady beside me again in her mid-70s. She permanently had an oxygen bottle and her eyes opened up. You mean, she said, I could have my VO2 max measured. And then the consultant can prescribe, exercises, and she can work to improve that. So, these are brilliant examples of the change. And the last example is the eco stethoscope, when I saw the POCUS device, I thought the stethoscope was dead, because POCUS means a shift for doctors. In the past, they had to listen and guess, and that was their training. Okay, and now they can look and see. With the Eco stethoscope, it's a US company, it will take an ECG. It will also do heart murmur analysis. And again, a test that used to have to happen in a hospital can now be done in the GP surgery, and you can diagnose valvular examples. And just one point, myself and John Sheehan, we ran an event last year at Fordham University, and we had a panel of doctors talking about these devices. Well, one of the doctors said he's now prescribing the AI stethoscope to his patients. So the patients are using it at home. So it's a massive shift to the left. And what we're going to see is a complete inversion of health systems from being an illness system to wellness system. And some of the AI devices, like the Eco stethoscope, like the Seismofit, are actually wellness devices rather than illness devices.
I'm not sure if John Sheehan's actually in the crowd today, but if you'd seen last week, the RCSI and Microsoft came up with the online course there for people in healthcare. Phenomenal what's happening within that. Anna, from your perspective and your experience, what do younger technologists and clinicians understand about AI that perhaps the traditional healthcare system doesn't yet grasp? And what's the leap we need to go on?
That's an interesting question. I might do a plug here because at EY we've actually partnered with RCPI to do the first national survey of a physician's perception of AI in Ireland. There have been other surveys done. So the Turing Institute, I do have my statistics on my little notebook here, because even as a data analyst, I forget numbers very easily. So 52% of clinicians surveyed by the Turing Institute were actually optimistic about the use of AI. So we hope the survey closes in November. We hope to get some kind of feedback, hopefully similar kind of statistics, maybe even a little bit more optimistic, because the issue, or the challenge here, is to really question what is happening with that 48%. Why are they not optimistic about AI? Is it more got to do with, again, the systems that they're working on, or in Ireland specifically, it could be that disconnected services. It's not a lack of data, but it's a lack of data standardization. Now that's going to come with the European health data space. So that will come inevitably to Ireland. But a lot of the data that we're capturing in Ireland in the hospitals, a lot of it is actually like free text. So how can we standardize that? There's a project even in St. James's at the moment, and they're looking at an AI medical coder bot. So this is helping clinical coders who their job manually is to standardize all of the diagnoses and symptoms in medical records. So they've developed a bot now to kind of help them streamline their workflows. So it's getting something that works in the workflow, again, going back to that time-saving element, not burdening them with extra time. And at the very beginning, we kind of talked about that. How can we get the patient to trust AI? But the first step is getting the consultant, the clinician, the healthcare worker to trust it first. And a lot of that, I think, revolves around training. We really need to up the training in undergrad, not just at masters or diploma level courses as well.
And final point to yourself, Filippo, you talked about some of the costing of doing that kind of speech to text. Anna spoke about training. Is there anything else that you're actually seeing as that gap that would be important to look to solve?
Yeah, well, one of the gaps that we've seen on the application that we've been implementing is that being only voice-based, we were missing some information from the visit. What I mean is that a practitioner would have to change behavior or speech patterns in order for the voice-to-text system to work. So, for example, if you're examining a patient next, quite often they would do something like, is it hurting here or here? If you go voice to text, obviously you can just detect here, this is 100% correct, but you won't know what the here is. So we are augmenting this technology with a visual model that we are training ourselves. We don't have data, so what we're doing is to use, we are generating synthetic data to train the model so that the model will be triggered by a word like here or there. It will take a picture and it's sent to this model that needs to be small enough to be where on the edge. And this way we can classify what part of the body has been touched. Is it the left? Is it the right part? Is it top or right? So all of this will augment the experience of the practitioners while visiting the patient and ultimately improving the accuracy of the solution.
I could go on. Fantastic. Thank you so much for being a wonderful panel. Please, can we have a round of applause for Professor Martin Curley, Dr. Simon Wallace, Alan Chevillier, and Filippo Sassi. Thank you very much.